Hello, welcome to section 13 of the online anatomy review. This time we'll be discussing the muscles of the lower limb and some of the fascia and tendons in association with those. Starting with the question, a 34-year-old male complains of pain on the sole of the foot. He reports that it feels like he's walking on glass, especially in the morning. His history is unremarkable except that he has recently started an exercise program 3 times a week to combat his obesity. Upon examination, he has point tenderness along the plantar surface of the foot and pain upon passive stretch. What is the most likely diagnosis? Plantar fasciitis is definitely the most common of these, especially in conjunction with obesity, increased activity levels, and this early morning pain that he was discussing. So those are all key features of plantar fasciitis. Shin splints are going to be microtraumas as the muscle attaches along the periosteum, and they tend to be sore at the beginning and after activity, but tend to be okay during an activity. Compartment syndrome gets worse during activity and will oftentimes be pale and blanched out. Stress fractures will be fairly consistent. This is a possibility, but it would be more pain associated with the dorsum of the foot as opposed to the plantar surface. And the tibialis posterior strain would have referral through the activity of plantar flexion. Now, moving into the muscles and the muscular problems of the lower limb, we have the idea of strains for muscles, and it's important that you know the basic strength apportioning of muscle strength, with 5 being full strength compared to the opposite side and 0 being complete paralysis. The difficult ones in assignment here are usually around number 4 or 3, with 1 being the ability to twitch the muscle but to not move it against gravity, 2 being able to move the limb but not against gravity. You have to have it in a plane where gravity is not a factor. 3 being active movement but not full strength or weakness, and 4 is also weakness. 3 would be more for profound weakness. And oftentimes the most strained muscles are the hamstrings, and there can be avulsion fractures that pull it away from the ischial tuberosity, especially in high impact or high burst sports such as soccer or sprinting. The quadriceps are oftentimes pulled, and the groin or the gracilis muscle is oftentimes strained as well. Active, passive, and resisted movements and what they indicate for a muscle versus a joint are going to be important as well. Remember, when you do active movements, it's with somebody contracting the muscles themselves, and passive movements are going to be with the assistance of someone else moving the joint through a range of motion. So this is going to give you more information about a joint itself. And resisted movements are going to give you specific information about the contraction of a muscle without the change in the joint angle. Combining those 3, you can oftentimes solve the problem of whether you have a joint pain, a muscle pain, or a combination. Several overuse issues of muscles and associated tendons, such as the one we discussed earlier with plantar fasciitis, shin splints, which are an overuse type of issue, and remember they tend to be confused at times with compartment syndromes, but compartment syndromes get worse with activity, and typically shin splints will at least diminish their pain throughout the activity and get stiff both either before or after. Bursitis is going to be an overuse or an impact. More common sites for these is going to be the trochanteric bursa and the patellar bursas that we discussed earlier. And then finally, tendinitis. The Achilles tendon is oftentimes ruptured through tenosynovitis, and people will report like they've been hit in the back of their leg with a tennis ball or a baseball bat, somebody that's hit them. Typically that's the tendon itself just rupturing and basically exploding into small sheaths. The quadriceps oftentimes get tendinitis as a result of things like Osgood-Schlatter's, which tend to happen in males during an active growth spurt during puberty, and after their growth plates close down, they get associated tendinitis. They're oftentimes going to have a very prominent tibial tuberosity as a result of that as well. Now, let's just go through some of the muscles and try to summarize the lower limb in a single page. We talked earlier at the beginning of this session where the thigh and the gluteal region is 4 compartments, the leg is 4 compartments, and the foot has 4 layers. So the general pattern for this summary would be 4, 4, and 4. And I like to think that if you can count from 1 through 6, you can actually remember all of the different compartments and what's in each of them, because each of them will represent the name of a muscle that you should be recalling. In the leg, 2, 3, and then the 3 plus 1 of the deep compartment, and 4 in the anterior compartment, so those all represent muscles. And then finally, the pattern in the foot is 3 muscles in the first layer, 2 muscles and 2 tendons in the second layer, 3 muscles in the third layer, and 2 muscles and 2 tendons in the fourth layer. Again, if you're familiar with all of these muscles at this point, move quickly through this just to make sure, but this is sometimes a nice simple way of not spending an inordinate amount of time on muscles of the limbs. So the anterior compartment has 2 muscles. Those are the sartorius muscle and the quadriceps, which of course has 4 heads. Then the posterior compartment is going to have 4 muscles, and it's a little bit of a cheat in that there are the 3 hamstrings, semimembranosus, semitendinosus, and biceps femoris, but I want to break biceps femoris into its long head, which is innervated by tibial nerve, and its short head, which is innervated by fibular nerve, or common fibular nerve. The gluteal compartment has 3 gluteus maximus, minimus, and medius muscles. It also has 6 lateral rotator muscles, which get 4 independent nerves, so we won't discuss the nerves of those, but you get piriformis, superior gemellus, obturator internus, inferior gemellus, obturator externus, and quadratus femoris. And then finally, there's one that we don't want to forget about that's arcing around to the anterior compartment as a flexor, which is tensor fascia lata. The medial compartment has 5 muscles, and I like to remember them with the mnemonic, physicians like big monstrous gonads. And those really break down into physicians, pectineus, like longus, big, brevis, monstrous, magnus, and finally gonads, which would be gracilis. So now you can see that if you can count from 1, tensor fascia lata, 2, anterior compartment, 3, gluteal, 4, posterior compartment, 5, medial compartment, and the 6 lateral rotators, you can remember all of the muscles associated with the thigh and gluteal region quite quickly. If you draw that out a couple times, you'll have them down. Then we'll move on to the leg, which we know has 4 compartments as well. We have a lateral compartment with 2 muscles, the fibularis brevis and fibularis longus. Remember, fibularis longus is going to also support the arch, the medial longitudinal and lateral longitudinal arches of the foot. The deep posterior compartment, which we know has 3 that are under soleus and 1, the popliteus muscle, that is above soleus. So we have tibialis posterior, flexor digitorum longus, flexor hallucis longus, and popliteus. You may know those first 3 as Tom, Dick, and Harry from the mnemonic that helps you remember their relationship at the medial malleolus. Then we have the superficial posterior compartment, which has the 3 muscles including gastrocnemius, soleus, and plantaris. Now, not everybody has a plantaris, but we want to remember it, because it's a useful graft muscle and can be used in facial reanimation surgeries or for replacing tendons in upper limbs that are affected by injury. And then we have the anterior compartment, which has 4 muscles: tibialis anterior, extensor hallucis longus, extensor digitorum longus, which sometimes has a component coming off of fibularis tertius, so we'll put that 4th one in, which is only sometimes there. but we don't want to forget about it. So there we have the 4 compartments of the leg, which have 2, 3, 3 plus 1 equals 4. So there's our 2 from the lateral compartment, our 3 from our superficial posterior compartment, our 3 plus 1 from our deep posterior compartment, and our 4 from the anterior compartment. Just for the sake of space, we're going to just do the pattern on this one, and we're going to do the rest of it on another sheet, just so it's not too small of an animation. But we have 4 layers of the foot. We have layer 1 with 3 muscles, layer 2 with 2 muscles and 2 tendons, layer 3 with 3 muscles, and layer 4 with 2 muscles and 2 tendons. Just as a beginning point, I want to talk about the fact that the layer 1 and 3 that have 3 muscles in them, there are 3 major compartments in the foot. This is just a way of dividing up the layers to remember it, but there's actually 3 functional compartments, and there's one around the little toe, one around the big toe, and then a compartment in between. And each of those 3 muscles is from one of those compartments. Let's see how this divides out if we pull it up. The general pattern we've already talked about, and I've got the nerve, artery, and vein that you can see in red running between layer 1 and layer 2. Then you can put in general contents of each of these, and I'm not going to go through them right now, but the 3 muscles would be 2 abductors and a flexor, abductor hallucis, abductor digiti minimi, and flexor digitorum brevis. And then we have the muscles of layer 2, which are 2 tendons and 2 muscles. Sometimes I'll call this the hairy dick layer because this has the flexor hallucis longus tendon and the flexor digitorum longus tendon, which some of you may know as hairy and dick. And then the 2 friends of dick, which would be muscles that associate with the tendons of flexor digitorum longus, quadratus plantae to help straighten out the pull angle, and the lumbricals to help flex the toes at the MTP while extending at the IP joints. Then we have layers of the foot number 3, 3 muscles again. This time it's 2 flexors and an adductor, and they're listed there for you. And then finally the 4th layer, which we're back to 2 tendons and 2 muscles, which are actually muscle groups. The way I remember this one is that we've had hairy and dick, now we only have the layer with Tom left in it, and this is what I call the Tom's big fib. Tom is tibialis posterior, and the longest, or the biggest, of the fibularis muscles would be the fibularis longus. And those are the 2 tendons that are coming from the extrinsic muscles of the leg into the foot. The 2 muscles are actually muscle groups, which would be the 3 plantar interossei, which adduct, and the 4 dorsal interossei, which abduct, abduct. How do we look at the veins, arteries, and nerves of the foot? Well, remember we talked about the midline of the foot being the 2nd digit. There's the doorway to the foot, the abductor hallucis, and you can see the medial plantar nerve coming in underneath the abductor hallucis and immediately splitting off from the lateral plantar nerve and distributing to the 3.5 digits and 4 muscles of the foot. The major motor component of the foot is the lateral plantar nerve. So if the foot is losing lots of its intrinsic musculature in any of the questions, look to the lateral plantar nerve as the culprit. It does 1.5 toes of sensation, and here you can see the muscles are going to be the lath muscles for the medial plantar and all of the rest of the muscles of the foot for the lateral plantar. This is just to remind you what the lath muscles stand for, and we're going to move on to ways of remembering what each of these muscles do without having to memorize them using pure brain power. The best way to do this is to think about what they do as they cross the joint. If you divide the joint up into anterior half and posterior half, you have dorsiflexors anteriorly and plantar flexors posteriorly. And then if you divide it in half from medial and lateral, you have everters on the lateral side and inverters on the medial side. And whichever quadrant these muscles pass across the ankle joint in, they will therefore carry out those functions. So, as an example, the extensor hallucis longus tendon crosses in the anterior medial compartment, and therefore it is going to be a dorsiflexor and inverter along with tibialis anterior. If you look in the other compartment, the extensor digitorum longus, except for the first tendon which crosses the midline, along with fibularis tertius, those will be dorsiflexors and everters. Looking behind the lateral malleolus, fibularis brevis and longus are going to be plantar flexors and everters, and then Tom, Dick, and Harry are going to be behind the medial malleolus, and they will be plantar flexors and inverters. And of course the Achilles tendon will cross in the midline and be a plantar flexor. So this will show you some of the muscles of the gluteal region and their attachment points. And if you need to go through those and remind yourself of them, please take the time to do that. I'm not going to take too much time just to read these off to you. One thing that I do want to point out on this slide, though, is that the gluteus maximus, gluteus medius, and the tensor fasciae lata are all innervated by the superior gluteal nerve, and gluteus minimus is inferior gluteal nerve. The lateral rotators, I think you don't need to worry too much about the innervations because they have 4 different innervations supplying these 6 muscles. The hamstrings will be coming off the ischial tuberosity except for the short head of biceps femoris, and this is susceptible to an avulsion injury, especially in young people. So if think about forced hip flexion or anything that will pull those hamstrings or stretch them too much could avulse a portion of that away. We've already seen the orientation of those. That's for a reminder of all the different lateral rotators. As we move into the muscles of the anterior compartment and the medial thigh, again, if you need to review these with a little bit slower time pace, please pause this and move through. Remember, we have the psoas and the iliacus muscles coming from the pelvis. They'll cross under the inguinal ligament as the iliopsoas and will attach to the lesser trochanter. Those are powerful muscles, that powerful hip flexors, and those can be stretched or damaged in forced extension of the hip, or they can be involved with inflammation and abscesses. You can see the attachment for the quadriceps is the rectus femoris is the only component of that muscle that crosses the hip joint. The other ones are isolated to the thigh itself by attaching to the femoral shaft. Then we have the 5 lateral or medial rotators, the pectineus, adductor longus, adductor brevis, gracilis, and the adductor magnus, which are all attaching around the medial edges of the pubis and the ischiopubic ramus. In the posterior thigh, we've talked about the gluteus muscles and the tensor fasciae lata, as well as the piriformis, which is an important landmark because the sciatic comes under it. There you can see the hamstrings component, and it shows the 3 muscles of the hamstrings along with the short head coming from the lateral side, where the femoral nerve is running between the biceps femoris and the semimembranosus and tendinosus. Remember, the semitendinosus is an important grafting tendon in that it can be used to reconstruct the ACL during ACL injury. One of the other tendons that can be used is the quadriceps tendon, where they'll take a bone tendon bone graft off of the patella and the tibial tuberosity to repair that, and the graft of the bone into the tibia and femur respectively will heal quite nicely. Let's move to a question. A 17-year-old nationally ranked long-distance runner is brought to the ER after she was forced to stop her workout due to severe pain in her left calf. 1 hour after stopping, the pain had not subsided, and she sought medical help. She complains of pain and difficulty with active or resisted dorsiflexion, plantar flexion, and eversion. She has no fever or swelling and heat over the affected areas. What is the likely diagnosis? In this particular case, this is going to be a deep posterior compartment syndrome. Anterior compartment syndrome has been affected because the dorsiflexion is painful, both active and resisted. On stretch, these will become painful. Shin splints is too much compartment being affected. Stress fractures should not be painful on active movement. And osteosarcoma typically will not radiate to all of these different compartments either. Muscle strain is not a good option because of the number of compartments that are affected, so the varied movements as well as active and resisted is indicating that there is a muscle problem though, and it's just too broad for one particular muscle strain, especially with a nationally ranked runner who does not report having a significant trauma or fall going with this injury. Compartments in the leg are important, and the compartment syndromes that you see in the lower limb either are from fractures with vascular bleeding into the compartments or from overuse, such as the case was in the previous example. The intermuscular septa that separate the compartments of the leg away from each other are quite thick, and the nerves traveling through them and the vessels traveling through them can be easily compressed with small amounts of fluid through exertional activity. So if you have these different compartments, we've talked about the muscles that distribute into them, and as far as the different compartments, we'll go through each of those muscles, and you can review these for yourself if you're not quite there on the basic anatomy, but otherwise we'll move through these very quickly. So we have the superficial posterior compartment with 3 muscles. We have the deep posterior compartment with 3 muscles under the soleus and 1 above the soleus. We have the anterior compartment with 4 muscles, although fibularis tertius may not be present in every person. And then we have the lateral compartment with fibularis longus and fibularis brevis. They used to be, about 20 years ago, they used to be called the peroneus muscles, and that's because the tibia itself, even further back than that, used to be called the peroneus bone. And that's starting to be switched now to the fibularis longus and brevis. I think that's something you need to be aware of because it could show up in the test either way, although I would be sure that they would put it in brackets at this point. Now we're just looking at the muscles and the layers of the foot. I wanted to say about the first layer that we have 3 muscles, 2 abductors and a flexor, and remember I had mentioned that they are in each of the major compartments, one towards the little toe, the abductor digiti minimi, the middle compartment, flexor digitorum brevis, and then the medial compartment with the big toe, which is going to be abductor hallucis. The rest of the layers are going to be the hairy dick layer, which has the hairy tendon, flexor hallucis longus, and then the flexor digitorum longus, which is going to have 2 muscles of the area associated with that tendon. And you can see from behind the tendon you have quadratus plantae coming off the calcaneus and going into the tendon to straighten out that angle that it pulls at the foot, and also 4 lumbricals which will be coming off of the deep tendons in flexor digitorum longus. This is also the layer that you see the distribution of the medial and lateral plantar nerves, arteries, and veins distributing. Layer, we're back to 3 muscles, 2 flexors and an abductor. Again, 1 for each compartment, 1 for the little toe, flexor digiti minimi, 1 for the oblique head and the transverse head of adductor hallucis in the middle compartment, and the flexor hallucis brevis in the big toe compartment. Finally, in the 4th layer, you have the 2 tendons coming from the leg, which is tibialis posterior and fibularis longus, and those will be helping to support the arches of the foot as dynamic stabilizers. And then we have 2 muscle groups, the 4 dorsal interossei and the 3 palmar interossei. Remember, dorsal interossei abduct the toes from the midline, and the plantar interossei adduct the toes, the midline being the 2nd digit, and here is how each of those will pull by their respective color. We don't need an adductor for the big toe because there's an adductor hallucis, and we don't need an abductor for each of the little or big toes because those are in the first layer of the foot. This concludes our review of the lower limb. In our next section,